তারপর পারভেজ আজকে সকালে চেম্বারে রুগী দেখে নাই, ওটা প্রিপেয়ার করে এটার জন্য বসবে। তারপর বললো যে আসসালামু আলাইকুম, ডক্টর শাহিদুল।
Yes. Assalamu alaikum.
Assalamu alaikum.
Alaikum assalam.
All set, ready?
Yes.
Yeah, our speaker is engaged in another talk. That is, he's presenting THR in trochanteric fracture. But I could not reach there. What a key YouTube Danny.
So he'll reach on time.
I am in doubt because that is started at 6:30 p.m. Bangladesh time. Indian 6 p.m. and it is of 2 hours. But there was 4 paper. One paper is for 20 minutes. Then 1.5 hours will be there. So discussion and other things. He might leave earlier. But I don't know. I hope that he will leave. Yeah.
So he is the main presenter. He has to come.
Yeah. He was undone because very closely there are 2 sets, and that is a paper. 4 people from India or 3 people from India, 2 people from Bangladesh. Although, what was
Other people are also there, sir. This
I
is
see.
why.
Where is Ali? Perhaps Ali is in the line. Or
Of course, sir.
yeah.
Yes.
He has appeared.
And when he wants, he just joined.
He's giving phone to you or somebody.
So you do more hip arthroplasty or knee arthroplasty in Bangladesh?
Hip.
Hip, sir.
Hips.
More hip.
Our
Then
people, basically, knee arthroplasty, usually it is done on the elderly people, old people. But hip arthroplasty often calls for younger people also.
Young.
So old people in Bangladesh sometimes doesn't deserve to do it. And most of the time they say our life is almost at the end. So why will go for this? Even the children wish to do it, they decline. The parents decline. And you know, there is a lot of money involved. So most of the time they decline to do it. But nowadays people are coming up when they see the result that other people are doing good replacement. So they are coming. Ladies are coming.
So what implant companies are there in Bangladesh? Zimmer.
In Bangladesh, J&J, Johnson & Johnson.
Yes.
They are most busy people here. Speed Nephew. Yeah. And previously there are some other company, but now some Indian company like Mary.
sir, GMAR is also there.
GMAR is for GMAR.
Striker is also there.
Yeah. They are for knee mainly.
They are
GMAR
very limited.
Yeah.
GMAR, Striker.
But in your clinic, do you see a lot of patients with advanced knee arthritis?
Yeah, that is true. Most of the patient comes with spine, knee, and neck. This is all about orthopedic practice. You know, spine, either spine problem, back problem, knee problem, or hip problem. These 3 regions occupy the most of the patients in our general practice.
So one question: do you see many primary osteoarthritis of the hip in Bangladesh?
Yeah, not that much primary osteoarthritis. Almost, I see secondary osteoarthritis people are possibly more.
Yes, in Pakistan as well, the primary osteoarthritis of the hip is very rare. So we see a lot of primary osteoarthritis of the knees. But hips, it is secondary to AVN, secondary to ankylosing spondylitis, rheumatoid, trauma, neglected trauma, failed trauma.
Surgery, yeah.
Yes. So neck of femur, screw cutting out or DHS cutting out. So failed hip fracture is one of the reasons for total hip arthroplasty. And AVN is a reason, ankylosing spondylitis. But because the rheumatologists are there and they're using biological agents, so we are seeing less patients with ankylosing getting worse.
Ankylosing as a whole, the number of ankylosing is less.
Yes.
Comparable to other places. But with DMRD and other biological agents, the severity is lessened day by day. You know, Dr. No, in our student life, we see a lot of rheumatoid problems, rheumatoid hands, rheumatoid knees, and others. But now it is very rarely you see it.
Yes.
Rheumatoid hand deformities, nodules, and other things. Because of
Yes.
DMRD, these are listening.
Yes.
Yeah,
Obviously.
these patients are listening day by day. Arthada,
Tawfiq sir,
Ali.
Assalamu alaikum.
Walaikum assalam. How are you, Ali? Ali,
I'm
আলিতে একদম আমি ভয় পাই। আলি যখন কথা শুরু করে তখন আর ওই থামতে চায় না। তখন পরে আর আমাদের জন্য কোনো কথা থাকে না। সেটা আমি আজকে ইয়ে করলাম মোশাররফকে, মোশাররফ আলি যদি শুরু করে আমাদের জন্য আরেকটু সেগমেন্ট আপ করে দিও। আলি আপনি এটার উপরে বলেন। তাহলে আমাদের অন্য কিছু বলার থাকে।
okay. I will not talk anything. You are senior guy and senior boss.
No, you must tell. You are the most experienced person.
Shahid Noor.
Yeah.
So both the two bosses are there. I will be silent, sir.
No. You are the most experienced person. You must tell about the
No, the actual idea is that we are here because of the juniors to make a platform so that they can play on that.
Right.
And so long we can give them some kind of information so that they become safe surgeon. We should be happy for that. And we'll appreciate Shahid Noor that he is accompanying us. And he's giving a lot of experienced talk on this special talk on the ankylosed hip. Very rarely can people have this kind of idea because we also have very limited experience. And I heard that you have done more than 10,000 surgeries. Oh yeah, this is amazing. This is amazing.
Tomorrow I am giving a lecture on complex knee deformities in Asian population requiring total knee arthroplasty. So it's going to be a very good, I'm trying to simplify the problems and giving you tips and tricks of how to manage very complex knee deformities. Obviously, you have to learn to do primary straightforward first and then difficult and then complex and challenging. But so if you are registered, then it will be nice to listen to this webinar tomorrow and you can ask questions. And all of you are most welcome to come to Karachi to my center because in a day I would be doing about 10 knee replacement. I do both knees at the same time. And complex deformities requiring primary knees and constrained knee and wedges and a stem and rotating hinge. Only today, before coming for this webinar, we've already done about 6 knee replacement and some other cases, arthroscopy, ACL reconstruction.
So, Shahid Noor, you will be happy to know that I'm giving this kind of services in Bangladesh for the last maybe 10-15 years. And my actual OP list is like that of you have mentioned. There's the primary knee replacement with arthroscopy and ACL reconstruction and hip surgery.
Very good, mashallah.
So,
mashallah.
there's almost a similar kind of things. And I have the experience of doing more than 7,000 ACL reconstruction and few thousands of arthroplasties. So, and I am doing my job in a tertiary hospital where there is a lot of limitations and it's very costly. So
I understand. So when I came back to Pakistan, we had a lot of limitation, but then gradually working hard to improve the system and having a clean air theater and getting the system and the OR staff working according to your standard to keep the infection rate less than 1% is obviously a very big challenge because you can do a very
Alhamdulillah, we are very, very happy that yes, we are keep continuing the things, but now it is the time to give the technology to our next generation. So I appreciate you thoroughly and I'm very honored to ask me to join into the tomorrow's webinar. I will try.
What we are trying to do now is that in my department, the younger trainees, I'm sending them abroad for fellowship. So we have a separate guy for tumor, a separate consultant for sport, separate consultant for pediatric, separate consultant for deformity correction. We are 8 consultants in our department, and 1 person does all the pelvis fracture. So even if it is coming in my on call, so we will give them analgesia, CT scan, and next day it is transferred under the care of Dr. Intakab. So he has got a very large experience of acetabular fracture and pelvic fracture. So subspecialty development and culture of referral will improve the standard of care. So somebody doing hand and somebody doing foot and ankle and somebody doing infected cases is a difficult problem.
Sir,
Yeah, Alhamdulillah, we have the issue is that in our NITO, the National Institute of Trauma, we have already divided the faculties of this orthoplasty.
I have actually been to National Institute of Trauma, and I was there many years ago at SARC Orthopedic Conference in Dhaka, and I gave a lecture many years ago, about 10 years ago.
So,
Sir, Professor Amjad Hussain joined. So as it is already 9:02, let we start. May I request Musharraf Hussain, you please start the webinar.
thank you, Dr. Fazlul Kasam sir. So, welcome to all. Today's webinar organized by ABC Bangladesh, ABC of Joint Replacement Bangladesh.
Musharraf, you please unmute yourself.
Hello, can you hear?
Yeah.
Okay, so welcome to all. Today's webinar that is organized by ABC of Joint Replacement. So today our topics is total hip replacement on ankylosed hip. It is basically a case-based discussion. We have good number of panelists and our speaker. Among them, we have Dr. Syed Shahid Noor. He is from Pakistan. Now he is a professor and head of orthopedic surgery, Liaquat General Hospital, Karachi. Basically, he is a president of Pakistan Arthroplasty Society, ex-president of Pakistan Orthopedic Association. He was the founder director of Pakistan National Joint Registry and founder principal of Liaquat General Medical College, National Medical College. He has a lot of experience in arthroplasty, around more than 10,000 hip and knee arthroplasty. And he has performed 40 to 50 revision arthroplasty every year. He is an examiner of FCPS in Pakistan College of Physician and Surgeon. He was awarded Best Academic Award 2018 and 19. Here he has a numerous publication and articles published both in national and international level. So welcome Dr. Shahid Noor. We have another legend, Dr. Rafiqul Islam. He is also a panelist. He is a professor and head of the orthopedic surgery, Ibn Sina Medical College Hospital, Dhaka. He is a renowned orthopedic surgeon in Bangladesh. We have also another legend, Plastic surgeon of Bangladesh. Is a senior consultant and coordinator, Joint Care and Wellness Center, Ever Care Hospital, Dhaka, Bangladesh. Our speaker, today's speaker, Dr. M. Amjad Hussain, is a professor of orthopedic surgery, now working as lab-aid specialized hospital. He was professor and head of the department of Dhaka Medical College. He was ex-president Bangladesh Orthopedic Society and now country representative of AO Alliance Bangladesh. And I am Dr. Syed Musharraf Hussain, working as professor, Department of Orthopedic Surgery, Jalalabad Rajiv Rabia Medical College. I am with you as a moderator. So today topic is total hip replacement on ankylosed hip. It is a case-based discussion. You know, it is a complicated condition, and it, due to its altered biomechanics, it produces lot of complication and disability of the other joint as well. So when you go for total hip replacement and ankylosed hip, it will reduce the symptom of a patient and can lead to a near normal life. But this type of surgery is a technically challenging procedure, and overall outcome is less satisfactory than the routine total hip replacement performed for osteoarthritis and other conditions. Moreover, it needs expertise and experienced surgeon in this field. So today's topic is total hip replacement on ankylosed hip. So I am now requesting our speaker, Professor Muhammad Amjad Hussain sir, please deliver your presentation. Please deliver your presentation. Professor Amjad Hussain sir. Sir, are you ready?
Yes, I'm getting ready.
Musharraf, please stop your screen sharing.
Yes.
Okay. So, guys, yeah. Okay, guys, how are you all? Assalamu alaikum and good evening to you all. Saeed Noor is here, and thank you, Mr. Moderator, Professor Saeed Musharraf Hussain, and our organizer and coordinator, Fuzul Haq Kashim, for again allowing me to talk in front of this august gathering. Our panelists, Dr. M. Ali, and also Professor Rafiqul Islam, and I hope that other guys are there. So let me share some of the thoughts. And as instructed by the organizer, coordinator, that what needs you go on talking, and then finally, after the completion of our deliberation, the questions will be asked. So I hope that our moderator will be starting. So our topics is, that there's ankylosed hip. Ankylosed hip doesn't mean that only ankylosis spondylitis. It means that whatever possibilities are there, and then the hip becomes ankylosed, there's no other options, and you have to go for surgery. So I'm starting my first case. This is a male, 24 years, bilateral ankylosed hip. Can you hear me all, Dr. Musharraf?
Yes, sir. Yes, sir.
Thank you.
You are audible.
Okay. So it's a ankylosed hip with psoriatic arthritis, and you can see the presentation that how the thigh has been abducted, and little bit externally rotated because lesser trochanter is very much prominent. And that is concentric reduction of the joint space, and some of the sclerosis is part of the both sides of the joints, because in the acetabular part as well as in the femoral part, femoral head. So, and you can see the X-rays of the spine, both AP and lateral view, and there is not much changes in the hips. I mean, in the spine, space is still maintaining, but there is lots of lordotic carp is there. We don't know what will be happening. So I can go to the next slide. You can see it. This is the case. You see the 27 millimeter of, his ESR millimeter, and CRP is 24.9. There is 25 milligram, and then ACLB 27 positive. And here, what I like to say that you can see the patient how he is standing. He's coordinating, or he can adjusting his. That is some sort of, what do we call it, kyphotic back or lordosis, loss of lordosis. So he's standing. What I like to mention here that we must see there are a lot of things are there, because I was just getting out of a session of Indo-Bangla. Indo-Bangla. There was a session going on. So I was there as a speaker also in the trochanteric fractures, comminuted cases I had to present. So the speakers were telling about this pelvis, spinopelvic, lot of, as Shahid Noor knows, that a lot of people have been a lot of papers, publications regarding these things. So you can case over here. What I like to mention here, we should remember that lumbosacral joint angle, which is 30 to 40 degree. And whenever it is less, that is the lordosis is lost, the kyphosis is increased. In that case, we should be very careful, and we should be very much, reasonable for putting our joints. So this is I know that this, this is absolutely has been treated so many, rheumatologists. So don't confuse it that it is, why not we are going to diagnose it. Diagnosis is already made. So many drugs, so many trials have been given by the rheumatologist of our country, and all these have been done. So finally, when the patient has been seen that nothing to be done, so he came to us. So this is the acetabular cup comes to more open position when there is, in the first, you can see that in the first case in our, this is the, how this curvature is there, the kyphotic back. So you must be very careful. And this is another, you can see how the pelvis and the back is there. This is for our, the younger generations, for our colleagues, junior colleagues. In ankylosing spondylitis, particularly when fixed kyphotic spine is there, so patient stands extended, his thigh is trying to hyperextend the thigh and try to walk. So this is the hyperextension brings the opening of the upper portion, particularly anteriorly. So the cup version and this inclination should be very much careful. So you can see here, I'm telling you, this is the anterior portion. And so if you are not careful, if we put the as usual normal cup, so there is a possibility of anterior dislocation. So this should be kept in mind. So this is what I like to show you. This is a case, the bar operative, how you see the flexion Thomas test, as you know, and it is absolutely, it is not that totally fused, very painful. The patient is crying, yeah, whenever I'm trying to put his, and so that is his, you see agony, how much agony he has. And then you see this, how the knee is extended. No, nothing wrong with the knee. So it is absolutely in the hip. So it is absolutely in the hip. So we should be, and as I told you, that his right thigh, right hip is already abducted in position. It is a fibrous display. It is not that bony ankylosis, it is fibrous ankylosis. So there is a lot of pain. And what I like to show you here operatively, usually we are putting the final cup in 40, 45 degree average, that is 40 to 55 or for 50. But here we should be very careful. We are putting less inclination, that is around 35 to 40 degree. I'm putting the final cup, and accordingly this the final insert is putting. So we should be cautious. I'm telling you, our panel of experts will be discussing all these things. What I like to mention here, that this is the bilaterally done, and I like to mention again one thing. The problem is your identification of the neck of the femur, where you are to cut. So if I failed it, I can confess you that this was my failure to identify the exact neck. So I was just striking with my sharp osteotome, and then what I did wrong, that I have damaged the posterior wall more or less a little bit. So I had to reconstruct. You can see the screws over there with the bone. These screws are there with the bone graft. So here you can see that how this cup orientation when sitting and when standing on the right side, and below abnormal functional cup orientation in sitting, and also in the right side, how it is going to be displaced or dislocated. So very important that how the cup positioning is important, and that will be discussed by our great panelist over here later on. So this is case 2, as it is diagnosed as ankylosing spondylitis straight way. There is no other options. I mean, nothing is there. You see how the spine, you see the spine, how the spine is fused. Oh, sorry. How the spine is fused, you can see on the right side absolutely up, and the hip is fused. So this male, 55 years at that time, long back, it was in 1996, our initially primary case. That time only Chanli was available, and it was used from Calcutta. And we were waiting in the operation room. A lot of my assistants were there, Dr. Masood, Dr. Parvez, and other people. So 1996, right hip. And then another hip is 2000. Again, it is also Charlie's hip. And the man is still is working in the New Market. He is a shopkeeper in the New Market. And I think this well-versed panelist, they will comment about the right hip, I mean, cementing position now, and whether it is recently this, the X-ray. I mean, so I believe they will comment about that. You note it, Mr. Moderator, because his cementing is already, loosening has started. So it will be discussed by our panelist. Okay, so 24 years follow-up. I think it is the highest follow-up. So it is glad that the patient is still, he doesn't want to do any surgery. He's working, as you see in the New Market. You can find him over there. If you like to buy some clothes, go to his shop and then buy it. Case number 3, again, very young man, 28 years, ESR 88, and CRP 151. Gentlemen, this is it. This is a very message I like to tell you. Most of these cases of rheumatoid arthritis, you want to encounter with high ESR, and CRP is also high. That doesn't mean that you don't need to go for surgery. It is not, as you know, that rheumatoid arthritis is not inflammatory condition, but not pyogenic. So here we have done this, and you see the pertusio is there. If you carefully see on the right hip, it is pertusio is there. So that should be kept in mind. And as you see on the patient, you can see that his right hip is already abducted a little bit and is externally rotated, and there is no movement also, or minimally movement. There is again some sort of ankylosed hip bilaterally, but right hip is much more, the wall has damaged and go inside in the pelvis. So this is another problem for rheumatoid arthritis. The bone becomes porotic also. That also should be considered in the mind. So this is a young man, 5 years to 7 years follow-up, and he is standing, you see, and you can see that how he is walking. He's a 20 years old guy, and he is walking normally, bilaterally done. So at least he has been gone back to his normal activity, and I am happy that we should be grateful to God that this sort of patients can walk. Remembering his position, you see how much it was difficult, but luckily And still after 7 years, 8 years, he is being working nicely and doing everything. And then third case, male 18 years. This is a hemoglobin 12.7, ESR 55 millimeter in first hour, CRP 3 milligram, HLA-B positive. This is a straight way. My panelists, our viewers can see that there is nothing left in the joint. You see, his joint is totally gone. There is no space in between, like rheumatoid previous cases. Here, totally, the fusion is achieved. There is a bone is totally articulated, and what do you call this, trabecules. So no movement at all. Here is a painless hip, you can see, with deformities. He had a fracture, so somewhere he had been managed to see the fracture line can be seen, and the plating has done, it is united. So this is another, this is a case straight way. You can see in this picture that how there was a big incisional mark in his thigh, and it was done. So, but he wants to walk because his hip is totally fused. So, so what in first surgery, left hip on 11th of April 2017, we have put this non-cemented total hip replacement, and we were very scary about his right hip because the implant is there and it was not far off. So we were not ready to do the same sitting. So we told the party that you wait a little bit, and then if it goes well, then we will remove the implant, plate, and then we'll go for intervention total hip on the right side. So this is the position, second surgery, plate removal, and the TAC on the right hip on 23rd of May 2017. So this is the post-op X-ray, and patient very happy, very happy to go back to his activities. At least he doesn't have any structural problem. He can move at least, and he was moving. And then you see, this is the situation, gentlemen. My learned panelists, they will be understanding that how bad it was. Probably a long stem would have been better, but what we did, you see, considering all the factors, financial side and other side, and particularly when the long stem, I think it is very difficult to get because 240 is the highest size so far available in our country. So again, this is not the fracture, originally fracture, so this is a separate site. Because the porosity is a problem. When there is patients cannot walk, the bone becomes porotic. And if there is something addition that, there is every chance of fracture. So this is refracture on 17th of August. We did the surgery on May the same year in 2017. And in August, he had this fracture. So sad. And what to do, I don't know. And I think our panelists will be, particularly will be helping here. And please note it down. In these sort of cases, complexities are there, very much difficult to manage. So then third surgery for fixation, because no other alternative, patient can't manage to go anywhere, and we have to do something. So as we have got some knowledge of AO, AO means that AO, we have got the implants, locking plate or other plate, and how to fix it and how to do it, particularly around this periprosthetic fracture. So with little knowledge or some ideas, because we are the AO fellow, so we know that what to do. So we did this surgery. You see the long, femoral plate, distal femoral plate, locking plate, and it has been done. And still this, you see the post-op X-ray on the right side, it is there. So previous surgery was there, and I'm not sure what is going to happen. You please note it down. Is it right or wrong way to do it, or it is okay? So finally, on the follow-up on 25th of May 2019, after 2 years, this is the follow-up. So this is union is hopefully God has blessed us, Allah has with us. So this patient, this young chap, we were very much praying that he should be okay. Otherwise, you see, very much damaging for a poor man with bilaterally. Those such a big problem. So many surgeries, so many surgeries. So ended up nicely. God has helped in this respect, and it is, I think, you can say that it is united or it is uniting. Okay, it is uniting. So this is that same chap. He's a very young chap, but only 28 years, and he's been working. He's been working so nicely with bilateral hip, with implants, with the plate in situ. We have not yet removed the plate, still is there. Well, I'm really afraid to remove the implants. So this is case number 4, doctor is 32 years, bilateral ankylosed hip with psoriatic arthritis with mental agony. And you see how the difficulty is because the protrusion is there. Protrusion, when it is there bilaterally, and the hip has almost pushed the superior wall and the medial wall is almost gone, or difficulty and porosis. And he has psoriatic arthritis because he has been treated. He was my student when I was in Sylhet Medical College in 96. At that time, he was in first year or second year. Then this is the situation. So you see how when I'm showing you, there is no movement, is minimum or no movement, and very, very painful. He has got, the rheumatologist said that he has also vasculitis and all these things. He has been given so many drugs, so many things. And he was so many depressed. And he married to his friend. So she told me, sir, actually he is not going to survive if we can't give him a good hip or a good life, because he's already very much. So we went for the surgery on 21/4/2010. I just briefed him for hours together that anything can happen, because I'm not an expert so much, but I can help you, I can help you, my team will be helping you. So he has agreed, okay, sir, go on, because you are my teacher in medical college in Sylhet. So I like to undergo surgery under you. So please do it. So you see, this is the situation. And this is the situation. Now he's a pediatric consultant at Fortune Medical College. Last follow-up on 9/9/2020. And 2020, because just 3 days, 4 days back, he has sent this video from his site, and he's been working. Oh, sorry. So this doctor is working. He's little gained weight, but fortunately he's happy with his wife, and he came to us last year, and he said me that, sir, I'm working, and still he's working for the medical college. He's working, I stare up, and that is after so many agonies, so many years suffering, at least he is moving. But I'm showing you that how his hands are deformed, his body is still deformed. So this is, we can discuss this. Another case, male 40 years, bilateral ankylosed hip with fixed kyphoscoliosis. This is a big problem for us. How he's standing, and his external rotated, and the thighs are absolutely abducted, or his totally kyphotic back, and unbelievable. He's from Sylhet. I think Partho Sharathi is here. I think he knows this patient. So this is 13.5 gram per DL. His hemoglobin is good. ESR is 41. CRP is 3. Fortunately, here CRP is always in ankylosing spondylitis, not everywhere. High up. ACLB 27 is straightly positive. So I don't know. This is a real tough situation, and here I should mention that our panelists should understand that, and they are better. Well-versed people, that how we are going to place this in the position and the table, operation table, and how we are going to do this. His whatever position, and anesthetic is also a question to be asked that how the anesthetist is going to, because he may fail in lumbar spine, spinal anesthesia, epidural anesthesia, even GA. Sometimes very difficult because total his body is fixed. So you see how his left hip is up, elevated, and the right hip is down because of the obliquity of the pelvis. So this is the situation. You see how this is, you see, whole body is moving, and so so this is really a tough job for us to manage. Yeah, the whole body is moving. You see, so and then how to go for osteotomy, and then making the whole thing in your control, and then go for finding out this acetabulum and reaming, and then yeah, and also patient is poor, so you cannot afford in these cases double operation. So particularly in our situation when the authority is very much strict. So we did this surgery in 6/6/2015, and with the right side you can see that how this obliquity should be maintained. On the downsided side, when the pelvic obliquity is there, downsided side should be, the cup should be more vertical, a little bit vertical. And on the other side, when there is exposure, and on the upside, there is elevated side, the cup should be more horizontal to cover, and the exposed portion of when the patient stands up. Here, the problem is this patient cannot walk. Actually, the swinging in locked gait. There is a term, swinging in locked gait, because the hip is totally fused, spine is fused. So what is that? Patient is just moving forward when the gate is already totally closed or locked. And so we have to be very cautious, careful in this, managing these sort of cases. So this is the situation. And after so many, 5 years, 5 years, yes, he's done in 15. So this is the X-ray, recent X-ray, and this is the X-ray, last X-ray, 19th April, yeah. And you see the patient is, yeah, this is what he's doing, you see. At least he's standing, and he's now in a bed, lying down in sillet. You see how he's side bending from this side to that side. And but we can't remember that he's right-sided cup, maybe, we don't know. We'll be having next follow-up, because we can ask him to come, or after the pandemic is gone, we can ask him, or we can ask him to send the X-ray, and that will be helpful for us. So this is the lateral view. We can remember that lateral position, sagittal plane is very important, and also in the when it is in the decubitus position, lateral decubitus position, we have to be coronal plane should be considered. And as I told you, that hip lifted, hip down, the angle should be measured, and the cup should be accordingly placed, horizontal or vertical. This is very important message to our colleagues. So this is arthroplasty remains the most effective treatment strategy to relieve pain and improve ambulatory status in these patients. So thank you all for listening and hearing me, for your patience sharing. Thank you so much. Yes. Mr. Moderator, now I think you can share and your views and your ideas and your any questions. Yeah. Can you hear me?
Yeah.
Yeah. Okay. Thank you, Mr. Panelist, Mr. Rafiqul Islam, Professor Rafiqul Islam, Professor Shahid Noor, M. Ali, and our Rizvi is there. So I think the big chaps are there. So nice to see all your smiling faces. So what I have said and what I have done is
okay. Thank you,
Okay,
sir,
thank you.
for your nice and elaborate presentation of very, very complicated condition. So there are so many questions, but I submitted all the questions, and I think that will cover all the participant question. So first of all,
I think the panelists are there. Let them
yes,
let them answer the questions. Right?
yes,
Okay.
I will give question, and all the panelists will give the answer.
Yes, yes.
So first of all, the ankylosed hip, it also not only hip is ankylosed, there is also knee and spine and other joint also involved. So my question is to speaker, Professor Amjad sir, how can you plan for surgery? What is your pre-operative planning regarding any ankylosed hip surgery?
No, as you said that it depends upon your clinical examination. When the other joints are mobile, only spine is a problem, but we are not going to address the spine because we know that what is going to happen. And the other joints, particularly the knees, if you do the hip, if there is any, a little bit 10, 15, 20 degree knee problem, that is also been addressed and that has been covered or that has been treated without doing anything in the knee, but you have to address the hip first. That is the question, right? So you evaluate the patient as it is already done by the rheumatologist or the other people. So considering your surgery, you can go for it accordingly.
If the both hip is involved, which hip should be the first address?
No, that depends on also the patient. If the patient works for, as I am very much in favor of young people to do bilateral because I cannot afford both sides differently. So what I do, and to me, the blood loss is not so much. So I think that the one-sided, well, we can do it very good if the patient is very much skinny, very much, the hemoglobin is less than 10. So that is a problem. Otherwise, bilateral can be done. Or the patient if prefers to do one side, I'm always happy to do that side. It's patient's choice. It's not my choice. Right. Thank you.
Professor Rafiqul Islam sir, can you add something, sir?
Yeah, thank you. The first question, how to evaluate the patient, is very important in ankylosing hips. You know, in case of ankylosing spondylitis, it is a generalized involvement. So initially there is a clinical evaluation and radiological evaluation you have to do. In modified New York classification, they have included clinically if the patient, if got the pain and the excursion of the lumbar, psoas positive, these are included. And in radiology, they included the SI joint and other things. But the thing is that you have to plan the patient as a whole, the hip, spine, and knee. So if the involvement, like Professor Amjad has shown some cases with kyphoid scoliosis also, they have decided to do the hip first, and then after correction of the hip, then go to the spine. Neither you cannot, spine is big surgery, you cannot evaluate the spine with hip flexed. And which one we will do first? It is the painful one you should do first. It is not always the choice of the patient, it is the painful one. Most of the thing, the painful one, if you do the painful one, the patient gets relief. And other thing is that there should be a free counseling with the patient about the outcome. As you have told, the outcome is not as usual for other THR patient. So outcome and prognosis should be safe to the patient. So happily, the patient who are younger, they used to come with a very inhumane aptitude and the attitude also. So when they get relieved of their crouching position, they become happy. They become happy initially. With the long run, it depends on how they behave. So these are the important things. And other evolution, as you told, that the anesthesia is very much important. The expert anesthetists do the epidural. Sometimes they fail it because of thick ligament of femur and goes for GA. GA is not also very good for patients who are flexed cervical spine also. So sometimes even I have seen the patient to give a tracheostomy to anesthetize the patient. Another is position. So these are very important things, and you must have lateral X-ray of the pelvis, lateral X-ray of the spine to evaluate the pelvic obliquity. Thank you.
Thank you, sir. Thank you, sir. Now, Shahid Noor, sir, can you add something,
Yes.
sir? How will you? What is your protocol for this such
I
cases?
agree with the previous speaker that we must understand that this is a very difficult surgery, and Professor Amjad Hussain has shown a very difficult surgery done very nicely. So it is a life transforming, quality of life transforming procedure. But yes, totally agree that preoperative evaluation, both physical, radiological, medical, anesthesia planning is very, very important, and patient counseling is important. You can use any approach that you are comfortable with. You have been trained to do a posterior approach, do posterior approach. You've been trained to do a Harding's approach, do a Harding's approach. And you should be prepared for any difficulty and eventuality or intraoperative complication. Variety of implant should be available. Trauma implant has to be available. In ankylosing, I've been using conventional hip, but more recently I've been using a dual mobility cup that increases the range of motion and decreases the chances of dislocation. And with the spinopelvic dissociation with the stiffness, this compensates for any mismatch between spine and pelvis. These cases happen in young patients, so you have to give them a best bearing surface that is the implant is going to last longer. The polyethylene should be highly cross-linked, and if the patient can afford, you can match it with a ceramic head. That's the best combination. A lot of these patients are osteoporotic, so identify whether they are osteoporotic by doing a bone density and treat their vitamin D deficiency and osteoporosis, and that is going to transform their life. Obviously, rheumatological assessment and continuing them with disease-modifying medication is going to help to prevent this ankylosing spondylitis getting worse. That's my little suggestion. Thank you.
Thank you, sir. Thank you. So my next question, we have seen in the Amjad sir's case, the patient having an ankylosed hip and ankylosis of the cervical and everything, he assumed as a hardboard. In that scenario, how can you, what is the position of the patient and what anesthesia is preferred for that cases? I am asking Professor Dr. Emali sir, please say something about position and anesthesia. Please unmute, sir. Fazlullah Kasem sir, unmute the Emali sir.
Ali is still in the board.
আলীকে দেখা যাচ্ছে না তো।
দেখা যাচ্ছে। তো Ali.
কই Ali কই?
Ali is there. Face is seen, but he's not unmuted.
Yes.
Mute
okay.
করে আছে।
Now I am unmuted. Oh, because the host was unmuted. Possibly Rafiqul Islam sir has given some tricks that Dr. Ali shouldn't speak.
Yeah.
Anyway, so first of all, hats up to Professor Amjad sir, because the difficult cases has been elaborately described and presented so nicely, and the operation has been done so nicely. Everybody is to appreciate him, and we salute him. This is an excellent job he has done. Thank you, sir. Now the question is that asked to me that what is the position in the pre-op management. One of the things. Number one is that patient need special attention. For the anesthesia, we know that the chest expansion is less. The cervical spine is stiff. So for general anesthesia, it's a very difficult thing. So it is recommended to go for the spinal epidural anesthesia and this kind of things. This kind of anesthesia is better because there is a long surgery and it especially decreases the blood pressure, and that is helping for the...
Ali sir, your voice is very low. Ali sir, your voice is very low.
Okay, so can you hear me now?
Yes, sir. Now it is okay.
Okay, so the thing is that this spinal epidural anesthesia is recommended, and the positioning of this patient is very difficult because if it is a single hip, then it is easy, but in a bilateral involvement, you may need a kind of a special arrangement of putting more pillows in the different spaces so that the patient can have a lateral position on which you can do the surgery, especially in the posterior or the hard hinges posterior. Thank you.
Thank you, sir. So in a chat box, there are some participants, some asked question about pre-op planning already been discussed. What are the ideal prosthesis for THA in ankylosed hip? So I am asking the Rafiq sir, please say something. What are the ideal implant for AS patient?
Actually, it varies. As Professor Shahidul told that he prefers a dual cup. And if it is available, that gives good range of mobility in those ankylosed hips. But sometimes it was ceramic on ceramic, but this is not now in practice because it's very costly. So once upon a time, there was a big head they choose to be metal on metal. So it varies actually in periods and times with availability and with the progression of the development of the implant. So it is not strictly it is followed, but I also support Professor Noor that a dual cup is preferable for this ankylosed hip because there is a very good range of mobility. You need mobility. Thank you.
Anything can add? Any panelist?
Professor Noor can be asked for this.
Yes, I think ankylosing spondylitis normally happens in young patients. So we need to put an implant that is going to last 15, 20, 25, 30 or even longer year. So there are two important aspects. One is the fixation and the other is the bearing surface. So a good uncemented, etcher-coated or porous-coated implant would do a fixation. But most of the aseptic loosening are because of polyethylene wear. So a good quality polyethylene wear is a highly cross-linked polyethylene, maybe with vitamin E antioxidant. Okay, and this can be matched with a metal head. But if the patient can afford a bit better, then the patient can have a ceramic on highly cross-linked poly. The ceramic has been there for many years. Initially, it was alumina, and then it was zirconia, and then now the fourth generation ceramic is a combination of alumina and zirconia, and they are called delta ceramic. So delta ceramic has got all the property, the fracture rate is less, and even with ceramic on ceramic, the chances of squeaking is less. So in my practice as well, I offer them that ceramic on ceramic is the best, but whether you can afford it is like Toyota Corolla is very good, but if you can afford Mercedes, then I as a surgeon is available to put a Mercedes and Rolls-Royce engine. So some of the most of the patients say, what is the cost of the surgery? And very few percentage of patients will come and say, put the best available in the world. Cost is not an issue. Obviously, this is a small fragment. So I offer them. So surgical technique is going to be for everybody, but choice of implant, best what the patient can afford.
Thank you.
That's true.
Anything
Yes.
add?
Yeah.
Emily sir?
Dr. Hassan must, please. He's very much acquainted with arthroplasty.
Hassan Masuda, can you say something?
Oh, he's not muted.
Okay, so one of the participants asked one more question. During operation, what is it? Yeah. How you manage perioperative proximal femur fracture during total hip replacement in ankylosing spondylitis patient? Professor, Dr. Emali sir, please say something. How can you manage perioperative femur fracture in ankylosing spondylitis patient? If happen. Please unmute, sir.
Emali sir, please unmute yourself, please.
Cannot do it.
Yes. Ali sir, we are not hearing you.
Fracture of the
yes, sir. Now we can hear you.
The question is the fracture, if it is happening.
Fracture and other complication, how can you manage it?
Is it he mean to periprosthetic fracture? Does he mean that? Or fracture during surgery?
It is during surgery.
During surgery, he asked fracture as well as other complication. If happened, what you manage?
Stiff hip. In a stiff hip, the complications like the fracture can happen. This fracture can happen in both the component, the acetabular component or in the proximal part of the femur. So that it all depends on what is the type of the fracture and why it will.
Your sound is not clear, sir. Ali sir, your sound is not clear.
Call some expert to help you.
But you can change your microphone, sir.
Yeah, now.
I can give an opinion.
Yes, sir.
Well, in these difficult cases, perioperative fracture is a possibility because these are young patients. They might have a small medullary cavity, and you might have difficulty in putting the smaller size implant. Because smaller size implant you have to put, you're already committed because you've already done the acetabulum and you're trying to put, and then in reduction your assistant might be very strong person and he's trying to help you and you hear a crack. So first thing is, please don't shout at your assistant. Keep your nerve under control and assess the severity of the fracture. Is it a greater trochanter fracture? Is it a calcar fracture? Is it a diaphyseal fracture? And what is the extent of the fracture? Now, sometimes you might have to evaluate this by checking under image intensifier. So don't rely on the fracture line at the operative side. Check the extent of the fracture, whether it's going, and then you have to plan. Now, the greater trochanter fracture can be managed by a circulage wire, a trochanteric grip plate, and a cable. But if the fracture line is going further down into the diaphysis, you might have to use a longer plate and combine it with a locking plate. So combination of longer stem and combination of a locking plate and cable. Obviously, where the stem is there, it might be very difficult to put a locking screw. So you will put a cable around the implant, and then beyond the tip of the implant, you would put. So these are the things that you have to be prepared with. For example, in a difficult case, we need to have a trauma implant and a locking plate availability of cable, availability of trochanteric grip plate, or a minimum K wiring set has to be available.
In addition to this, if there is an acetabular fracture,
Professor Amjad has shown that there is a screw fixation. So it all depends on the type of the fracture in the sternum that can be managed with the plate and screws.
What about the bone grafting? Do you put bone graft in these cases, because these are osteoporotic? And what is the source of bone graft?
The femoral head. The femoral head and the cancellous bone that you have taken out to prepare the acetabulum, keep it handy. Obviously, this will be helpful.
You don't use allograft bone in addition? Not
I'm lucky that we have a bone bank in my department, so that is handy. But you can take bone graft from the posterior iliac crust. From posterior iliac crust, you can take a lot of good quality bone. And in the diaphyseal fracture, you can actually take the fibula and use it as a stud graft or cable.
Yeah. Yes. Next.
Musharraf, you please unmute yourself. Yes, now and talk.
What are the tips and tricks for desired rimming in ankylosed hip for acetabular cup preparation? I am asking about, please, Rafiq sir, please, can you say something?
What are the tips and tricks for desired rimming in ankylosed hip for acetabular cup preparation? Actually, for cup preparation, it is very difficult sometimes to assess the cup position. So you must address 2 points. One is ligamentum flava and one is stall. And you should rimming and approaching the tall and the ligamentum flava. And another line they follow, that a horizontal line from anterior spine to gratiatic nose. I cannot recall the name of the line. And if you should do perpendicular to that line, that goes concentric cup positioning and cup rimming. And you must be careful about the medial wall. As Professor Amjad has shown, some of the cases there is protrusion. So we must be careful there. If there is lack of bone, you must put bone up there. A lot of bones from your head or other sources you should put there. Sometimes they put some types of, thread, sometimes the thread to contain the bone there. So these are the things to make a acetabulum for cup test. So I think some other expert can add something. But Rizvi Bhai, I cannot see Rizvi Bhai. Rizvi Bhai has done many cases of hip arthroplasty. Yeah, you can add about.
Okay, thank you, Rafiq. I do say Syed Noor. Okay, Assalamu alaikum, Syed Noor. It is nice to see you in a webinar.
Yes, we should add that. And Professor Abdullah Rizvi said to speak some of the things because.
Okay, so this is Professor Amjad has nicely presented. The irony in our part of this world, the young surgeon has to do most difficult cases. When we started doing arthroplasty, we started with the most difficult ones. Okay, Professor Amjad has already shown many of the difficult cases he has done nicely, and many of them has actually exceeded 20-25 years. This is very encouraging to see. Okay, today's topic actually is a difficult topic, ankylosis of the totally replacement in ankylosis of the hip joint. Okay, this is a very difficult arena, and Amjad has rightly said that ankylosis can be of different reasons. Okay, ankylosis spondylitis is one of them, where we do normally see mostly bony ankylosis. Okay, and young patients do suffer from ankylosing spondylitis. And another problem with ankylosing spondylitis is spine is involved. When spine is rigid, whatever problem in the hip joint, that actually results in is severe disability, and you have to do something unless if you want to make the patient mobile. But ankylosis due to other reasons, like many kind of arthritis, Amjad has shown that cases presents with a different kind of problems. Some with mostly pain, some with some limitation of the movement of the joints, okay. Some with extreme pain. Say rheumatoid arthritis patients, they present with pain. Pain is the main reason for them, and joint is destroyed with sometimes they present with patricial sort of deformity in the joint. But in ankylosing spondylitis, they present with body fusion, okay, with spine involvement. So these cases, actually, we have to take a lot of preoperative workout to address this kind of patients. I have some observation about this kind of patients in doing ankylosing spondylitis, especially. Okay, ankylosing spondylitic patients, as you know, these young patients, they behave better with the surgery. Rehabilitation with them is easy because their hands are normal. Okay, but when patients with ankylosing spondylitis having both spine involved, hip joint involved, knee joint involved, and ankle joint. I have a patient actually. I operated 50, 60, 17 years back. He came lying straight on a trolley. Okay, young fellow. He had spine ankylosed, both hip ankylosed, both knee ankylosed, ankle ankylosed and deformed. So I did both bilateral hip joints. I did bilateral knee joints, and I did osteotomies, corrective osteotomies at the ankle to make the ankle plantigrade. Okay. During these surgeries, I learned something, a few things. Okay. What would be the approach for the hip joint of those cases? Okay. I do follow when patients presents with flexion and external rotation deformity. External rotation deformity, if you go from the back, then you may have difficulty in finding the neck and cutting the neck, okay, because that is the area where you do mistake and cut not only the neck, cut part of the posterior wall of the cerebellum, as Amjad had mentioned, and similar thing happened with me in one instance. I cut part of this cerebellum during cutting the neck. So when the hip joint is externally rotated, so go from the anterior side. Okay, when the neck is open, maybe you have some flexion deformity that can be addressed as well. So in the other way, if the hip joint is internally rotated, you have space at the back, go from the back. So this is regarding the approach of the hip joint. The soft tissues apparently seems to be very tough. It's not that true. Tissues are friable because in the case I mentioned, when I was doing the knee joint, okay, in one instance, when I tried to revert the patella, I detached the ligament patella from this tibial tuberosity. Okay, so it was a serious problem. So I had to refix the ligament patella there. So when I was doing the other knee on other day, the same patient, I was very careful about the distal attachment. What happened? The proximal attachment was disrupted. So tissues are friable and easily and it's not that tough. So second teaching I learned. Third thing was that bone is relatively soft. Okay, so fracturing a femur can occur, and these are usually a spiral fracture. So Shoaib Noor has nicely mentioned how to handle it. Most of the things that don't lose your temper. Don't lose your temper. Assess the damage, not only by X-ray. Sometimes you'll have to open up the femur to see the distal part of the fracture. Okay, so there are so many ways to fix that. Regarding the dislocation of the hip joint, when it is a bony ankylosis, you cut part of the neck, okay, and try to have a outline of this acetabulum and then drill it carefully, okay. So, but when it is fibrous ankylosis, okay, with some kind of protrusio acetabuli, then dislocating the hip joint may be difficult. In that case, you may have to cut part of this posterior rib of this acetabulum, okay. What I do actually, if it is a fibrous ankylosis, after anesthesia, when the patient is in supine position, I try to mobilize the hip joint so that all the fibrous tissues are broken, so the movement of the hip joint is easier. Then try to dislocate by cutting the part of this posterior wall. If that does not happen, then you cut the neck and try to bring out the head, if possible, by piecemeal, so that you don't damage the posterior wall. Okay. Regarding the anesthesia, somebody has mentioned that, okay, anesthesia may be difficult. You will have to assess that. You have to talk to the anesthetist before the surgery so that you can give anesthesia appropriately. Nowadays, fiber optic scopes are available, laryngoscope, fiber optic laryngoscope. That makes the life much easier. And sometimes when you cannot give endotracheal anesthesia, then what do you call it? Pharyngeal cup is there, pharyngeal cup. So you can use pharyngeal cup if the anesthetist is convergent with pharyngeal cup. So anesthesia is also a problem. Regarding the rehabilitation with the ankylosing spondylitis is easy because patient is young, patient is motivated, patient is having upper arms normal. So the patient can use different kind of weights and can be mobilized easily. Regarding the other kind of patients having, just for example, rheumatoid arthritic patient with a lot of involvement in the other joints, okay, these patients are difficult patients. So every patient is different. So you will have to assess those and
that's the question.
Plan accordingly. Regarding another problem, Amjad has slightly mentioned. Okay, when this hip joint is pathological, so there is deformity of the hip joint. When spine is involved, this deformity of the spinal is involved. So in that case, positioning the patient is very, very difficult. So if the pelvis is in flexion, then you you get a kind of orientation of the cup. If the pelvis is extended, then the reverse thing happens. So you will have to be careful in positioning the cup. Sometimes the judgment from this, your own judgment may not be enough. So before fixing the cup, okay, when you are using the trial cup, so take X-ray or use your image intensifier to check the position of the cup. Okay. Some people do use, what do you call it? They use computerized navigation. You have navigation in your center, then it is easy, but this is not available in our country, and I am not sure whether it will be available another next 5 to 10 years or so. So we'll have to be very careful in positioning the cup. Okay, and fix the cup. Doing surgery appropriately is most important. Whether you are using a cemented cup or a non-cemented cup, it matters, but it is not that important because we have seen cemented cup we used 15, 20 years back, still working. Amjad has shown one case, it's a very old case, done in 1996. Patient is still working. So, and fortunately or unfortunately, the cup fixation was not that appropriate. It was not ideal. Position of the cup, cementing and everything was not ideal. But even then, you are a very lucky surgeon. Patient is surviving with that kind of cup for the last 24 years. This is very interesting. So our experts are doing this kind of difficult surgery. So hopefully our young surgeons nowadays have the opportunity to learn from these experts. So improve your knowledge, study hard, and you know, Amjad has slightly mentioned this alignment. Spinopelvic alignment is very important. Okay, position in the cup is very important. Orientation is very important. So be careful. Okay, thank you. If we get chance another time, then I will try to add something more as well. Thank you, Shahid Noor, for your excellent, what do you call it? Contribution.
I have a question.
Yes, sure.
Can
I show that patient where we did this both hips, both knees, 16, 17 years back, still.
Please, one question is to you: that do you advocate to do preoperative CT or MRI for cup positioning? Do you think that it will be helpful?
You can use
preoperative.
Preoperative, yes, you
CT
can do
or MRI.
Scan 3D or MRI. No MRI. 3D CT.
That is here.
Pelvis. So that can give you some idea. Okay.
My question
now
there
are places they have 3D printers. 3D printers. They have their printing done. They have their model and they can assess what to cut, how to maintain the orientation, or how much posterior wall you have to keep.
Some people advocate, some people doesn't advocate to do CT or MRI. Dr. Shohid, please, do you have any to add anything? Oh, he's not in the line. What about Dr. Shohid Noor's?
Professor Shohid Noor, please unmute yourself.
He's trying first.
No, unmute kore den.
No, he muted himself.
He's trying.
Dude, unmute yourself. Clicking the microphone in your computer. At the
Kashim sir, your side okay? Kashim sir?
My side is okay. I do not unmute him.
Sometimes that happened. Again,
Professor Shohid Noor, please unmute yourself.
He's not.
No, your device is muted. Professor Shohid Noor, your device is muted. Please unmute yourself.
Can you hear me now?
Okay.
Okay, fine.
Yeah, thank you.
So what was the question?
Question was initially any tips on cup orientation, acetabular cup orientation. That was the initial question. And we add that, do you think that the operative CT can help to for cup orientation?
You can make a templating with the CT, but it is the positioning of the patient during surgery and getting the orientation. And very rightly said by the professor that you can put a trial shell and you can get an image or X-ray to confirm if you are not very sure. Some of the cases, the cup might be lateralized. So if you don't have the facility, you can actually put a 2 millimeter drill medially and check the depth of the bone left so that you can further medialize. So that is my experience of putting the cup. You want to put your cup in right inclination and right version, and you have to medialize as well. So preoperative templating, not really CT scan, but preoperative templating will help you with the correct size of the cup, and correct orientation will be intraoperative. And you can check it under image if you're not sure, or get an X-ray on the table.
Okay. Thank you, sir.
Sir,
I think
can I show my case?
Yes, sir.
It would not be possible possibly because there is a chapter. Shohidru will speak something.
Okay.
Okay. Okay, you can show one. I don't know.
It will take 1 minute.
Moderator will. Yeah.
Can you see?
Yes, sorry, sir. I apologize everybody.
Charlie, you have given Charlie.
Thank you, everybody.
Not Charlie.
It's not Charlie. It looks Charlie.
This is both hips. Both.
It's a Charlie Elite.
Elite, yeah, Charlie Elite.
A Charlie Elite. Okay.
Yeah.
Okay, this is ankle. Okay, this is the band. So everything, everywhere. Actually, I put 2 hips, 2 knees, and an ankle. This is osteotomy, and it is 16, 17 years done. Years back. Still maintaining. He's not very active. He can work. He can maintain his livelihood. He has a small shop. He's maintaining that shop. Okay. He is Mr. Mitu. He's now 37 years old. Okay. Thank you.
Thank you, sir. So thank you, sir, Rijvi sir, for your nice tips and tricks regarding all the aspects. So thank you. Thanks again. So we are at the end of the session. So now I am requesting, we have a legend with us, Dr. Partho Sarathy Som. Sir, would you please add something or say something regarding our webinar? Please unmute, sir. Please unmute, sir.
Oh, sorry. Thank you.
Okay.
Thank you. I am actually from Sylhet, for remote areas telling actually. I like to say my thankful gratifications and felicitation to Amjad, my friend, for his very nice presentation and work he did for a long time actually. And I have been observing some patient done by him in Sylhet actually in different way actually. And actually, I am thankful to my friend Professor Rijvi, what showed this very nice case to us actually. I really welcome our very our foreign expert. He is Syed Shahid Noor from Pakistan. His eminent man is there. We got our very eminent orthopedic surgeon actually, Professor Rafiqul Islam of Indian Hospital with us. Is very known to me as American. I've been acquainted with it for a long time actually. I'm seeing in a very good platform. I feel proud of him actually. I like to congratulate. I get very much good to see a very eminent surgeon, Professor M. Ali with us actually. Anyway, this is my introduction. I'm thankful to my junior colleague, my very beloved Dr. Musharraf for nice moderation actually. Actually, so many discussion has been made regarding the operative technique, this and that, and it's very, very worthy for us. And I am thankful to everybody. I am just writing some of the questions actually to the all panel of experts, also the speaker, learned speaker, I should say. I think actually, what is your opinion regarding the spinal surgery in ankylosing spondylitis? In American rheumatology concept in 219, they are not advocating the spinal surgery. They're advocating the hip surgery. Hip surgery is recommended. This is the latest thing. What I've gone through the journal and American College of Rheumatology 2019, latest. There, I'm drawing attention to Rafiqul Islam, what it told about the teriparatite, actually in that lecture. They thought about the osteoporosis problems. That is the osteopenia during operation and there is some calamities. And they are advocating teriparatite for it. What Professor Rafiq told in the last probably in last other webinar meeting actually.
Yes.
They are advocating an NSI and they are advocating other thing. I am saying about the and this some question. The one-sided arthroplasty will not restore the perfect mobility and mortality, mobility and morbidity. One-sided arthroplasty, what is the result? I don't know it actually. They are advocating bilateral replacement always actually. This is the literature. And I am asking regarding some drugs. Latest, that is the tumor necrotic factor inhibitors, sulfasalazine. This is modifying drug, methotrexate. They are telling, the latest literature telling, they are actually they are acting in the large joint very well, and they are actually reducing the need of arthroplasty, reducing the need of arthroplasty. And other day telling that we are stopping the drug before the operation. You should stop the drug. Whether you need any post-operative medications for better result to the all the panelists and all the speaker. My question. Number 3, the operative consideration as told is the multi-system involvement, and actually CT scan was done. Whether you need DEXA for the patient of osteo, that is the ankylosis found before surgery. Number 1. Number 2, regarding the I am telling that this is not what probably discussed. The very important complications of this surgery, the heterotrophic calcification. What you've got actually? How do you manage it actually? So thank you very much for hearing me, and I want your valuable advice suggestion. I felicitate everybody. I feel honored to become with you. I thank you everybody, especially my foreign expert, Sir Sohid Noor from Pakistan. Thank you very much.
Thank you, sir, for your nice discussion. So we are at the end of the session. I think this discussion help us, and the participant will get knowledge regarding arthroplasty in ankylosed hip. Though it is a complicated situation, complicated condition, still then, if you do arthroplasty accurately and perfectly, definitely it will help the patient, and definitely it will help the patient to back to normal life. So now I am requesting Dr. Sohid Noor, please say something about the webinar and take-home message.
First of all, I'm extremely thankful to the Bangladesh Orthopedic Society to have invited me. It was a very good discussion, very difficult topic, very nicely presented by Dr. Amjad Hussain. He had shown difficult cases. And to my young surgeons who are actually starting arthroplasty, they must understand that this is a difficult case and should not be done by inexperienced surgeons. So preoperative planning and to be done by an experienced surgeon. Obviously, very rightly said that rheumatologists can control early cases of ankylosing spondylitis, and these patients might not require total hip arthroplasty. But when it is a completely fused joint, then correctly done, it is going to transform the quality of the life of the patient. So this webinar was very interesting. And I think these similar webinars you should continue, and I'll be happy to be a panelist again, and would love to come to Bangladesh and would invite other faculty from Bangladesh to come to Pakistan. And you can send junior surgeon to Pakistan at my center in Karachi. We do large volume of my practice is more a knee replacement. Tomorrow I'm doing a webinar on difficult primary total knee replacement. So people who have registered can actually watch and ask questions. So thank you very much. Assalamu alaikum.
Thank you. So before handing over to microphone to Fazlullah Qasim sir, I again thanks all the panelists, speakers, and the participants for their active participation and made the webinar fruitful and successful. Now,
Dr. Musharraf, one thing before going to Dr. Fuzul, Professor Partho has told about the heterotropic ossification, what we do. Basically, it is not very common in our area, the heterotropic ossification, as it is seen in Europe and other Western countries. So here we practice giving indomethacin tablet for say 4 weeks to 6 weeks. Indomethacin.
Do you advocate low dose radiotherapy?
No, not necessarily, because that has adverse effect also. Indomethacin cures acute in a very good way. It doesn't need for radiotherapy. I have got one question to Professor Shodhir and Professor Amjad. As Professor Amjad showed one.
Sir, please excuse me, sir.
Yeah, 1 minute.
Sir, 10 March 26, we do not want to longer it more than 1.5 hours, sir.
Just one question from Professor Amjad presentation. He has shown one case of having high rise ESR and CRP. So in an active case, should we do surgery or should we wait? An active case of rheumatoid problem. This is the question relevant to the case. Okay, I apologize for that.
If we want to discuss, this is a so academic topic, and there was so different and diverse type of cases. We can discuss hours, but now only there is 16 participant is there, all the left. So we should not bother the people. It is my consideration, and now you will think whether you will discuss this, what question you will arise, you will discuss or not.
Actually, a Zoom consists of 1.5 hours. It is not yet 1.5 hours.
Just a happy minute.
Sir, only 3 minutes left, sir.
Yeah, okay.
No, what he asked, in rheumatoid arthritis, you will have.
Fazul Qasim is right. Amjad, I'm with Fazul Qasim. Okay, maintaining time is very, very important. Okay, because many of these participants has already left. So I would request Fazul Qasim to finish this webinar as soon as possible. Okay, Rafiq, you can have your answer from Partho. Okay, Partho. Okay.
I do not have any. I do not have any answer to ask. I have given question to Professor Amjad. Okay, there is only 3 minutes. Professor, Dr. Fazul can conclude it. Yeah.
Yes. Fazlullah sir, please.
I am sorry, Rafiq sir, and we can talk with each other if we want to clarify some questions.
Now, this question is not given for me. The question is for the younger groups who are attending this. Okay, thank you.
Okay, they will learn gradually.
Yes,
Don't teach everything in one webinar.
I want to congratulate Professor Amjad Hussain. He presents very difficult cases, which is nicely managed by him. And most important thing, he kept record of his cases. This is very important and what is very uncommon to us. We are doing many cases, many work, but we are not keeping records. And he nicely presented. We are very much grateful to Professor Shahid Noor. He managed time for us. He was in our rehearsal webinar also. He was so generous and he contributed a lot to this webinar. I am also thankful to Professor Rafiqul Islam sir and Dr. M. Ali. They managed their time and contributed a lot in this webinar. I am grateful to our great teacher, Professor Khandakar Abdul Awal Rizvi and Partho Sarthi Shom sir. They contribute, they enrich our webinar. Our next webinar will be on 19 September. That is in the next Saturday at the 9 p.m. And next topic is the total hip replacement on dysplastic hip. You all are cordially invited. Thank you, everyone. Stay safe and healthy. Assalamu alaikum.
Thank you, sir.
Thanks to moderator Dr. Musharraf. Very nice.
Thank you, sir.